Hi, Terry Kuti again with Deep Sea Foundation. We are continuing our discussion with Dr. Minas Chrysopoulo and Dr. Ramon Garza from PRMA in San Antonio. So gentlemen, I had nipple sparing, skin sparing mastectomy, but I get a lot of questions from women about the process of reconstructing nipples. So I'm going to let you take over. And if you could bring in the topic of, does insurance pay for this or not? That's another question. Would you like to start today or this time, Dr. C?
Sure. From a cosmetic result standpoint, it's always best if you could save the nipple, especially if you're having implant-based reconstruction. But if you can't save the nipple, if you don't want to, you have several options for nipple reconstruction. Usually that's not performed at the same time as the initial reconstruction. So when someone talks about immediate reconstruction, what that means for most people is that the reconstruction process starts at the same time as the mastectomy. Doesn't mean it finishes at the same time as the mastectomy. So most people will need more than one stage, more than one procedure to get the final best cosmetic outcome. And for most surgeons, the nipple reconstruction is saved until a subsequent stage, usually the second stage. So with a tissue reconstruction, the area where the nipple and areola used to be is replaced by skin as part of the flap, part of the tissue that's been moved there, wherever it's come from. And then at the second stage, that existing skin that's already there that replaced the nipple and the areola is refashioned into a nipple and areola. And there are several different ways to do that. We use a technique called a bow tie technique. It's a modification of another technique. It's a modification of a CV flap. There are different little flaps, different ways to take the tissue that's been moved up there and make a nipple out of it. It's a bit like origami. So you've got the nipple reconstruction aspect, and then you've got the areola reconstruction aspect. The areola can be reconstructed using a skin graft from another part of the body, or it can be just tattooed. There are lots of different ways to do it. In our practice, we don't like to skin graft from other parts of the body. We use the tissue that's already there to make the new nipple and nipple areola, and then we tattoo it, either a 2D or a 3D reconstruction to provide the final pigment, and 3D also adds to the detailing that you can have, like the Montgomery glands of a natural areola, for example.
Which are the little bumps.
Little bumps, exactly.
So,
exactly.
Dr. Garza, how do you guys go about with the second part of the areola tattooing then?
Yeah, that's a great question. So, the phases of the breast reconstruction is the first phase, again, as Dr. Chrysopoulo was pointing out, is to kind of create the initial breast mound. The second phase, depending on the type of reconstruction that was done initially, can involve a number of things. But if it's an autologous tissue reconstruction, again, in the form of the flap, that's the opportunity for us to put some finishing touches on the reconstruction. So any areas of contour irregularity, any excessive scarring, that's an opportunity for us to revise the breast and create the best cosmetic outcome possible. The nipple reconstruction is often done at that time. Sometimes that is done in the office with the creation of the nipple bud. So the nipple and the areola create the nipple areolar complex. So the nipple is the projection part, and the areola is the colored part. The tattooing is done usually in the office 3 months after the nipple reconstruction. So if it's done in the operating room during phase 2, it's 3 months after. We have to allow the tissues enough time to heal, and after the tissues have healed, it will have a better ability to accept the pigment from the tattooing process.
Okay.
And then
foreign to me since I didn't have this done. So
Yeah.
that's interesting.
And then you don't need to have tissue brought in to create the new nipple and areola. So for implant-based reconstruction, so ladies that didn't have any sort of flap, they just had the mastectomy, and then the incision was closed over an expander or over an implant, then the nipple reconstruction, the technique is actually the same. It's just that we use tissue that's left behind rather than tissue that's been brought in. So the concept is the same.
Okay.
So the nipple reconstruction, the type of reconstruction has no bearing on whether you can have a nipple reconstruction or not. So any woman who has had or man who has had a reconstruction can have a nipple reconstructed. Doesn't matter whether they've had a tissue reconstruction or an implant reconstruction. And actually, you don't even need to have a breast reconstruction to have a nipple reconstruction, right? So as long as you've got chest tissue there, if you want to be flat but have a nipple, then you can have that done too. And so that's important, say, for some men it's much more important for them to have a nipple because they're okay with the contour, or they just need a little bit of fat grafting or something for the contour. So there are lots of little nuances, but ultimately
so I would think then, if no matter what type of reconstruction you're doing, whether it's implant or autologous, then while you're in the phase 1, the transferring of the tissue or putting the implant in, then you have to kind of think ahead with the skin that you're using and how that's going to possibly look in the future for nipple reconstruction. That has to be part of the planning, right? Is that making sense? Yeah.
Most of the time, yeah.
Yeah. Okay, great. That was good information. Thank you so much.
You're welcome.
All right.